see if this, does this work? Yeah. I have pockets today. Very deep pockets. Good morning. I think that's going to be it then. Okay, we have a really small class. Okay, do you remember anything from yesterday? Do you remember anything? You're like, no, nothing? Any terms? Any phrases? Nothing? Okay, that's great. Thanks, guys. Okay, at least I have my slides anyway today. So we're just going through some extra suffixes. That's all we're going to be doing today. I have some videos on some procedures. You do have to know the procedures for this unit as well. Okay, so the quicker that we finish, the quicker I'll obviously let you go, okay, because this is a long day for everybody. I hate these mics. Okay, let's see where we finished. Okay, so yesterday we talked a little about the upper intestinal system, heartburn. Did you look over any of these phrases? Any of these terms? No? Okay. We won't spend too long on it. Okay, we're going to move on with the module. Like I said, I know there's a lot on these slides. I don't think I put it on Moodle. I put Unit 5 up for you, but this is not up yet, just in case I want to add a few more procedures or a quiz maybe at the end for you. Okay, so this is about 20 slides in your module. I know it's a lot. It's all on one. Okay, but I just put the most important ones, and these are all coming on your exam. Okay, so make sure you know what esophageal stenosis is, GERD. So this is really tested, GERD, your gastroesophageal reflux disease. All these abbreviations are really tested in this unit. Make sure that we know the difference between emesis. Do you remember emesis? Vomiting, so hematemesis, that's coming in your quiz, and ectasia as well, which is the dilation. Pepsy and phagia. Dyspepsia and dysphagia. Do you remember dyspepsia? The difference between dyspepsia and dysphagia. What does phage mean? Do you remember? To swallow. So dysphagia is obviously difficulty swallowing, and dyspepsia is difficulty digesting. Make sure we know the difference between stenosis and stasis, which is always like stop, and a spasm, which is our involuntary contraction. IBS, our irritable bowel syndrome, is also coming. Rhaphianoplasty, our suture and our surgical repair. That's what we did a little bit of that yesterday. Denti and odont, they mean the same thing. Bucco means cheek, and seal, and labi means lips. Stomat, remember, means mouth. Okay, try not to get confused between stomach with that one. And lingual and gloss is tongue. That's kind of all we did really yesterday. I know you guys were like a little bit asleep. Cirrhosis, we have to know that. And coal. Coal is one of the most important terms, actually. It's very heavily weighed in this unit. So I know you're all still like a little bit asleep. I'll just go through today. I was going to go through, I thought I might finish it, but if you're all asleep, I might not. We'll just go through some imaging and procedures. I have some gross videos for you as well, so you can get a better idea of what some of these procedures are. And what else? Oh yeah, imaging and some therapeutic interventions. If we have time, we'll do some of the abbreviations at the end. I know this is a really long unit, okay? It's a really long unit, but you have now until next week to get through it. So the quicker we start, the quicker I'll let you go. Endoscopy. I think we know what an endoscopy is at this point, right? Endo meaning inside or within. It doesn't mean just in or incision. Some people were still a bit confused about that. So endoscopy is heavily weighted actually in this unit. So we need to really understand it, and I have a video showing exactly what it is. EGD, okay, EGD, all these terms are going to be really important. You are tested on them. I know it seems like a lot in the beginning, but it's not too bad. So EGD, your esophagastroduodenum. So this is three sort of sections. You have your esophagus, your stomach, and your duodenum. So this is our upper gastroendoscopy. Then you have your colonoscopy and your laparoscopy. colonoscopy and your laparoscopy are examples of our lower intestinal. So you do need to know which are the upper and which are going to be the lower. They're a little bit difficult to imagine on the slides or in the module. So I found like a good video of what the EGD actually is. We'll just take a minute while you're waking up. You can have a little look at it. So this actually is a good video. It has a lot of the terms in it. So let's have a look at exactly what it is.
The upper gastrointestinal or GI tract. The GI tract includes the esophagus, stomach, and duodenum, which is the first part of the small intestine. The test is also known as an esophageal gastroduodenoscopy or EGD. It's done using a tool called an endoscope, which is a long, thin, flexible tube that has a light and a tiny camera. The test helps find problems such as ulcers, infections, or growths. It can show the causes of swallowing problems or dyspepsia, nausea and vomiting, acid reflux, bleeding, and abdominal pain. Before the procedure, you may have a physical exam, blood tests, or other kinds of tests. You'll be asked not to eat or drink for at least 8 hours before the procedure. Tell your healthcare provider about all the medicines and supplements you take, any allergies you have, and if you're pregnant or might be pregnant. Your healthcare provider will explain what happens during the procedure. He or she will also talk with you about any risks or complications that may occur. You'll be asked to sign a consent form that gives your healthcare provider permission to do the procedure. Read the form carefully and ask questions if anything is not clear. An upper endoscopy takes about 20 to 30 minutes. When it's time for your test, you may be given medicine to help you relax or sleep. This is called sedation. This medicine is usually given through an intravenous line put in a vein in your arm or hand. Your throat might be numbed with a spray or liquid, and you'll be given a small plastic guard to protect your teeth. During the test, you lie on your left side, and the endoscope is placed in your mouth and moves down your throat. Air is used to expand the GI tract so your provider can see the lining more clearly. You may feel some pressure or discomfort from the air. The scope sends pictures of the GI tract to a video screen. Your provider looks at your esophagus, stomach, and duodenum for problems such as bleeding, inflammation, or growths. Using small tools inserted through channels in the endoscope, he or she can take small samples of tissue to send to a lab. This is called a biopsy. In some cases, your provider will remove small growths. The endoscope is then removed. After the test, you'll need to rest for about an hour to let the sedation wear off. This kind of medicine lasts for a while in the body, so you'll need a family member or friend to drive you home. Plan to take it easy for the rest of the day. If you had a biopsy, the results will be ready in about 7 days. Call your healthcare provider if you have any of the following: nausea and vomiting, vomiting blood, stomach pain that doesn't go away, black tarry or bloody stools, trouble swallowing, or fever. To learn about more procedures and screening, please subscribe and support us. In the next video, we will show the colonoscopy procedure, so stay tuned. Thank you.
The colonoscopy. So it is a little bit difficult to kind of understand some of these procedures, so it's really helpful to watch 1 or 2 videos to understand exactly what they are. Okay, so you will be tested on what is an EGD. So esophagogastroduodenoscopy. Okay, so 3 parts, and we have a little bit more to go through. The colonoscopy, okay, that's with the scope and the light and the camera, and is to examine the lining of the colon. And a laparoscopy, which is a viewing of the liver through the abdomen. So here's an example. Gas is pushed into the stomach and it lifts away from the organs so you can have a better view. So we're going to watch another one on what is the colonoscopy. Hopefully it won't be. Here's our sound.
A colonoscopy is a medical procedure that lets your doctor look inside your colon and rectum for problems such as ulcers, inflammation, bleeding, polyps, and tumors. A colonoscope is the tool used to perform a colonoscopy. It is a thin, flexible tube with a light and video camera on the end. It is inserted through the anus into the rectum and is carefully guided up through the colon, all the way to the cecum. The colonoscope can usually be used to enter the very end of the small bowel, known as the terminal ileum. The front tip of the colonoscope contains a video camera which sends real-time images to a computer screen so that your doctor can examine the colon. The front tip also has a light, a channel for water irrigation, a channel for air and water, as well as an instrument channel. The irrigation channel is used to flush water or air into the colon to remove debris or stool and see more clearly what the inside of the colon looks like, and to check for polyps. Special tools such as tiny forceps or wired loops or snares can be passed through the colonoscope to remove polyps and take samples, called biopsy, of suspicious tissue in order to look for signs of cancer. A colonoscopy usually takes 30 to 60 minutes and is performed in a hospital or clinic by a trained doctor, known as a gastroenterologist. You will be offered a sedative to help you relax during your colonoscopy, and you will be placed on your side for the procedure. Your doctor will carefully insert the colonoscope into your rectum and advance it to the end of your colon, to your cecum. The colonoscope bends, so your doctor can move it around the curves of your colon. Your doctor might gently press on your abdomen during the procedure, or ask you to change positions occasionally to help move the scope through the colon. During the entire procedure, a magnified high-definition video from the colonoscope plays on a monitor in real time, so your doctor can thoroughly examine the lining of your colon. Video may be recorded, and photos are taken as well. A small amount of air may be blown into your colon to help expand the passageway so that your doctor can see better. This can make you feel pressure or mild cramping, but can be eased by taking slow, deep breaths. The colonoscope is then slowly pulled out while your doctor carefully examines the inside of your bowel. If your doctor finds polyps or suspicious areas during the colonoscopy, the polyps will be removed and small tissue samples will be taken to be checked for signs of cancer. Polyps are usually not cancerous, but they can change into cancer, and that is why they need to be removed. Polyps are removed with biopsy tools or wire loops that get passed through the scope into the colon. The most common removal technique is called snare polypectomy, where the polyp is surrounded by a wire loop, and then an electric current in the wire burns off the polyp. The polyp is then pulled through the instrument channel and collected for biopsy. Other methods are available depending on the size and shape of the polyp. Polyps contain no nerves, so you won't feel pain during their removal. After your colonoscopy, you will be taken to rest in a recovery room until the effects of your sedation wear off. You may feel some gas or cramping, but this will quickly pass. Because of the sedation used during the procedure, you will need a family member or a close friend to drive you home. You should take the rest of the day off and not make any major plans for 24 hours. Before you go home, your doctor will share the results of the colonoscopy with you. If a biopsy was sent to the lab, it may take a few days or longer to receive the results. Depending on the number and size of polyps found, as well as how clean your colon looks, based on the quality of your bowel prep cleanout, your doctor will recommend when your next colonoscopy should be done. Your doctor will also provide instructions on the follow-up care required at home and how to recognize complications in case they occur. Colonoscopy is generally a safe procedure and complications are rare. If a polyp was removed or a biopsy was performed during your colonoscopy, there is a very small risk that you may have small amounts of blood in your stool for a few days afterwards. However, if you experience severe abdominal pain, fever, dizziness, or continued heavy bleeding from your anus, call your doctor right away. You should always discuss any questions or concerns you have about your colonoscopy procedure, results, and post-procedure with your doctor. Your doctor is there to help you through the process and answer any questions you may have.
Okay. It's pretty cool actually to see some of the procedures. In the module, colonoscopy is heavily there. Okay, it is heavily there. Okay, do you feel like you have a good understanding of what a colonoscopy is? Yeah? Okay. A laparoscopy, if you wanted to go and watch some videos on that, you could, but it's not as heavily weighted as the colonoscopy. So the endoscopy, you will have to know what an EGD is, a colonoscopy, and a laparoscopy, and exactly the what, why, and when. Imaging, okay, imaging. So like I said, coal comes up a lot. Coal comes up a lot in this module. So cholangiography, obviously we know that coal is bile or gall, angie is the vessels, and graphy is the process of recording. So it's obviously a little bit more difficult and different from a colonoscopy. Cholangiography, you have to be able to get into those vessels. So how do you do that? It's a little bit more difficult. This word here, your barium swallow, comes up a lot. Okay, you will need to know what a barium swallow is. It's on your exam. It's on your quizzes as well. So that is the contrast material. So that's injected into your veins and then it's traced through your biliary system. Biliary obviously means anything that produces, stores, or releases bile. It didn't explain that in your module, what the biliary system is. So once the contrast material is injected into your veins, then the X-ray is taken, and you can see up here, I know this, I think this came out of your module. I thought it was all right. And it traces where it actually goes. The PT-HC and your ERCP, you will have to know what they are. They're tested on them, and you will need to be able to pronounce them, and it does take a little bit of practice. So your PT-HC, your percutaneous transhepatic cholangiography, okay, and you will need to practice saying that sometimes, percutaneous transhepatic cholangiography. This is where the contrast medium enters through the needle, through the abdomen wall, into the liver. I think you have a question on what is a PT-HC test. Okay, it's looking for the liver, and HEPAT should tell you that. ERCP, okay, ERCP, it's a little bit more complicated. You will need to know what that is and be able to pronounce it. So this is a little bit of both. Okay, the last one there, your ERCP. So you're not just injecting, you're also using an endoscope, and we saw that in the colonoscopy. So it's a little bit more advanced and obviously a bit more intrusive. So it's called an endoscopic retrograde cholangiopancreatography. Yes, I've been practicing that all morning in the car. It does take a while, okay, so an endoscopic retrograde cholangiopancreatography. Okay, so you have to keep saying that, cholangiopancreatography. And you can see by the way that it's broken up, tography is the process of recording the pancreas, your vessels, and then your colon. So endoscopic retrograde cholangiopancreatography. And once you get to practice these terms, they do become a little bit easier. But you do have questions on what is a PT-HC test and what is an ERCP test. Okay, and I didn't have videos on that. You have a number of questions. There's a lot of slides on imaging. So I just took the most important ones here. You have questions on what kind of image is going to be taken. I have underlined the important words here that's going to give you a clue. Okay, so computed tomography, it's a CT or a CAT scan. So what you're going to see in your exam is certain terms or words, like what imaging procedure creates circular arrays of X-rays, or what imaging procedure produces cross-sectional images or into slices. When you see that word circular, cross-section, or slices, you're going to check a CT or CAT scan. They're the words that you're going to be looking for in your exam. They're the words that you're going to be looking for in your final. What imaging creates slices or cross-sections? That's a CT scan. The magnetic resonance imaging, that's your MRI. So it'll ask you what imaging uses magnetic waves. I think that's a super easy question. Or it'll say what imaging procedure gives you all three planes of the body. Okay, that's your MRI. And I found this picture, the difference between the CT scan, your CAT scan, and your MRI scan. You can see your MRI scan is a little bit more detailed. Diagnostic sonography. Son means sound. You can also call it an ultrasound. Do you remember what ultra means? Ultra means beyond the normal range. Okay, good. That's coming to you pretty quickly now. So it means beyond the normal range of hearing. So diagnostic sonography, it might ask you the question of what is the best imaging procedure for fluid-filled structures, and that's going to be the ultrasound. Scintigraphy, this is the last one here on the slide, scintigraphy. This is the only nuclear imaging. So this is where you have radioactive material is injected into your system, and then it's traced. Where does it go? Okay, and that's good to check, like the liver and the bile ducts. So it's only a very, very small amount of radioactive material. It's pretty much the same as just an X-ray. So everything I've kind of put in yellow, you have a question on that, for sure. You have a question on your exam and you have a question on your quiz. Everything in yellow. What is a CT scan? What does it use? What is an MRI? That uses magnetic waves. What is sonography? That's obviously an ultrasound. It uses sound waves for fluid-filled structures. And then what's scintigraphy? You need to know that that is the only nuclear test that you use here. If you were to look at Unit 6 or Module 6, that's the one that the doctor goes for the obesity, for our case study. Again, the ones in yellow are the ones that you're going to be tested on. Okay, so the different types of tests. I know this is like really boring in the unit, the different types of tests and procedures, but it's heavily tested. So you do need to, in this module, also know the different types of tests. So Unit 5, you're kind of learning how to label. Now you want to know how to diagnose. So you have the FOBT. Again, like I said, you're really tested on all these abbreviations. What does FOBT mean? It's the fecal occult blood test. It might be nice to know that occult means hidden. So this is when you're looking for any sort of blood in the stool. And it's called, we use a guaiac, okay, guaiac test, which is, I'll just put it in there. If you didn't know what guaiac was, it's a wood chemical that reacts with blood. And I have a little picture up there. The liver function test, you do have a question on that. The liver function test, so that tests for the presence of enzymes and bilirubin in the blood. You can see from the picture there the ALT and the AST. You will need to know what they stand for. Again, it's all about that, the alanine transaminase and the aspirate transaminase. When these levels are elevated in the liver, it's usually an example of liver disease, fatty liver, or maybe cirrhosis. You do need to know cirrhosis, like I said yesterday. And then finally, you have your bilirubin test, which diagnoses liver disease by measuring the amount of bilirubin in the blood. And that's just done by an index here, so that's pretty easy. So everything on this slide and everything in yellow, I've just named the three most important tests that you need to know: the FOBT, the liver function test, and the bilirubin tests. Okay, they're the three that you kind of really need to know. And what do they test for? Okay, what do they test for? So obviously, bilirubin, test for bilirubin in the blood. Liver function test, check for an increase in enzyme. And the FOBT, you need to know that that checks for blood. Easy peasy? Am I talking too fast? No, you're like, no, yes? Yes? Okay, so therapeutic interventions, okay? I wasn't going to do this, but there is a lot of questions on therapeutic interventions, especially the gastric bypass. I was going to bypass this myself. I was not going to do it. But you do have some questions on it. For example, the BAR and the IACT. So, okay, so the bariatric surgery. Have you heard of bariatric surgery? Some people call it lap band surgery. I think in America they call it lap band surgery. I've heard that before because it's kind of like a banding. So your gastric bypass is when you, and it is a lot actually in the unit, and what it means. So bar means weight. I like to think of chocolate bar, okay? And there is a question on what does bar mean, and bar means weight. So you can call it bariatric surgery. Lap band surgery is what they call, and it's where they just take a portion of the stomach and they make it really, really small. So actually you don't feel hungry a lot, or you get kind of full really, really quickly. I had a friend who got it, and he could only have like 2 spoonfuls of food, and then like totally, totally full. Have you heard of gastric bypass? You probably have. It's kind of a popular procedure actually, and I have a video on that. Ectomy, we know that's a surgical removal. Like I said, everything in yellow you do have questions on. What is a gastric bypass? And then the gingivectomy, you know that ginge means gums, yeah. And gastric what? Gastric sleeve. What do you mean gastric sleeve? Gastric sleeve surgery. I haven't heard of gastric sleeve surgery. Where did you hear that one? Huh? Because you did it. You did what? What surgery did you have a surgery? Yeah? And what is that? Is it? There's different ways I know that you can connect those ones. Okay, there's different ways. You can do it from the side. If you look, I don't know if anybody had the LAM book. Okay, they can connect it here, and it goes in here. So what surgery did you have, if you don't mind? Okay, maybe it's just a different term. Okay, we have gastric bypass, you have lap band surgery, bariatric surgery, and you call it gastric sleeve. And can you describe the procedure? Like, how did they do it? What happened? Yeah, okay. 80%, yeah, okay, good stuff. Did you feel like it, how was your recovery? Was it? Okay. It's a kind of an intrusive surgery, okay? It's kind of an intrusive surgery. It's not a surgery you want to be taking lightly. But I know gastric bypass surgery, it's really advanced, and every year they find like a new way to make it better. So there is different ways. You can cut the stomach, or you can connect two different sections. And we'll have a little look at the video so you get a better idea. Gingivectomy, this is the removal of a portion of the gums, and sialadinectomy is obviously the removal of the salivary glands. And paracentesis, this came from your module. I know it looks a bit weird. Paracentesis or abdominocentesis. Do you remember what centesis means? I think we had that on the removal of the fluid. Okay, good stuff, removal of the fluid. So let's see if this will work. Because there's different types of ways to do this surgery. Hopefully you guys will be
To
doing
gain
it one
access
day.
to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Okay, so it looks a little bit complicated, but like it says in the video, what you do with your lifestyle is also really important. I had a friend who got this and nothing really happened, okay, because they weren't willing to change their lifestyle. So, but people get it for many different reasons. So bariatric surgery, lap band surgery, or gastric bypass surgery, whatever way you want to say it, is all the different terms to use it. However, just take what they use from the module. Okay, just take what they use from the module. I'm just going to do one more slide, and then we'll be finished. I'll get to your question. Abbreviations. Okay, these are abbreviations. These are the most important ones that we're going to need to know. When I look through your exam, they're all there. Okay, they're all there. I love the way you take pictures of it. Okay, it'll be up there on Moodle. So GB is gallbladder. GI, make sure you know that it's gastrointestinal. BE, barium enema. Do you know what an enema is? No, an enema goes up the back way. Okay, the enema goes up the back, usually in a pill form, and you hold it in the back until everything comes out. Usually if you're going to do a colonoscopy, the doctor will give you an enema. either up the back, or it'll be drunk. Okay, it'll be drunk. BM, we need to know that means bowel movement. G tube, okay, this is your gastronomy tube, a stomach tube. So it's a tube that's inserted to the abdomen wall to introduce nutrients to the stomach. You might have seen that before, where you might have like a tube in the stomach. You might have seen somebody have that. Okay, the food is going directly into the stomach, missing the esophagus. GERD, we know that from our very first slide, or gastroesophageal reflux. We have to know that, that comes up. IBD is inflammatory bowel disease. Make sure you know the difference between inflammatory bowel disease, your IBD, and your irritable bowel syndrome. So you have an IBD and you have an IBS. Okay, so IBD is inflammatory bowel disease. IBS is irritable bowel syndrome, and that comes on the first slide. BR is bright red blood per rectum. That is a question. Bright red blood per rectum. HBV is hepatitis B. Make sure you don't confuse that with the HPV virus, okay, the papillomavirus. TPN, that is a question, total parenteral nutrition, means that all the nutrients must be administered through intravenous, so it goes through an IV. So this is where you want to totally bypass the digestive tract, okay, and it goes in through the veins instead. NPO, okay, this means nil per ounce, which is Latin for nothing by mouth. That is a question. So if you ever see that on a form, nothing by mouth. And PUD is a peptic ulcer disease. These are the main abbreviations that come at the end of the module. You do need to know them, what they stand for. You don't need to know how every single procedure is performed. But like I said, you do have writing on your final. Okay, and I think using some of these abbreviations might be a nice question. Okay, you just have to learn the spellings then for a few of them. Okay, obviously I wouldn't give you GB, that's too easy for gallbladder. But PUD, okay, peptic ulcer disease, and that might be like a writing question. Okay, you're not going to have to explain in long detail what everything means. If there's anything else on the slides or in the module, I'll stick it on the slides. Monday, I'll give you maybe like a group quiz, see how you're getting on with it. And then Tuesday, unfortunately, you have to start the nervous system. Yay! Isn't it exciting? No. Okay, fine. I think that's it. That's all I had on the slides. That is your unit. Okay, that's your unit. I'll put that up. Make sure you go over it and some of those terms. I'll let you go. If you have any questions, I'll be here for the next 10 minutes before I go. Yes, you had a question? Question? Anyone have a question? I'll be here. It's what?